Welcome to Language Access Matters, the podcast that dives deep into the crucial role of language access in public services and businesses. I am your host, Carol Velandia, and I invite you to join me on a journey of discovery and empowerment. Language access is not just a matter of convenience. It is a fundamental human right and the key that unlocks doors to essential services and opportunities. In this podcast, we'll explore the far reaching impact of language access, examining how it shapes not only healthcare, justice, and education, but also the world of business. Through thought provoking interviews, insightful discussions, and compelling stories, we will unveil the power of language access. We will hear from professionals who bridge communication gaps to provide quality care for diverse communities. We will explore the intersection of language, law, and justice, and the crucial role that interpreters and translators play in ensuring fair and equitable treatment. We will delve into the challenges and innovations as well as how language access opens doors to effective communication and inclusion and how it makes our society more equitable. But our exploration doesn't stop there. We will also uncover the profound impact of language access in the world of business. We will hear from entrepreneurs, industry leaders, and experts who understand the value of inclusive and effective communication and how it drives success in today's global marketplace. Language Access Matters is your platform to understand the significance of language access in these vital sectors of society. We will shed light on the barriers faced by individuals and communities and the innovative solutions that promote inclusion and equality. Whether you are a healthcare professional, a legal expert, an educator, a business owner, a linguist, an advocate, or simply passionate about the power of language, this podcast is for you. Together, we will navigate the challenges, celebrate the victories, and advocate for a world where language access truly matters. So, join me on this enlightening journey as we uncover the impact of language access in healthcare, justice, education, and businesses. Let's amplify the voices of the 25 million people that don't speak English in the United States and those that don't speak the dominant language around the world. Those voices deserve to be heard and empowered, and we need to empower ourselves to build a more inclusive future. Welcome to Language Access Matters. Let's embark on this transformative exploration together. Welcome to Language Access Matters. This is actually the 10th episode, and we are celebrating our first year anniversary, and I am delighted to have such a distinguished guest, Mara Youdelman. She is the Managing Director for Federal Advocacy in the Washington, D.C. office of the National Health Law Program. She also served as founding chair and commissioner of the Certification Commission for Healthcare Interpreters. At the NIHELP, Mara coordinated a national coalition to develop a consensus-driven agenda to improve language access policies and funding. Mara is co-author of Ensuring Linguistic Access in Healthcare Settings, Legal Rights and Responsibilities, and from the Commonwealth Fund, 3 reports on promising practices for providing language services. She has authored a 50-state survey of state statutes and regulations on language access and written about how Medicaid can pay for language services. Mara is recognized as a national expert on language access and has participated on expert advisory panels for the Robert Wood Johnson Foundation, the National Committee for Quality Assurance, the National Quality Forum, and the Joint Commission. Welcome, Mara. It is a privilege to have you with us today.
Thank you so much for inviting me, and I'm thrilled to be your 1-year anniversary speaker.
Yes, I am thrilled about that too. Mara, how did you get into this work?
Well, professionally, I started working on language access issues when I joined the National Health Law Program back in 2000. I started about 2 weeks before President Clinton signed an executive order bringing greater national attention to language access, and a couple weeks before the Department of Health and Human Services issued the LEP guidance that many of us have been looking at since 2000. So I was tasked with reviewing those documents and doing a presentation for the advocates who we work with. And since then, I've just been continuing to work on language access at the National Health Law Program and then in conjunction with a lot of other partners.
Is limited English something that always interested you, or was there anything in particular that sort of draw your interest to that, or any life experience that you had, or learning any other language, any experience you can relate to limited English proficiency?
Well, I wish I was fluent in another language, and so far that has still evaded me. When I was really little and when I was going to nursery school, I actually attended a nursery school at a school for the deaf where my mom was a teacher. And it was actually a really interesting experience because I was one of the only hearing kids in a room full of children who were deaf and hard of hearing. And if you can think back to the early 1970s, hearing aids aren't what they are now, and people had to wear very big attachments on the hearing aids and wires that would come from the hearing aids down to a microphone that they would wear on a lanyard around their necks. And in any other situation, they would sort of be the odd one out. And in this situation, me at 4 years old and 5 years old, wearing thick Coke bottle glasses and a patch over one eye, I was the odd one out. And that experience has still stayed with me. I followed my mom's career over the years. She's always been working on improving access to individuals who are deaf and hard of hearing. And as I grew up, I certainly was involved in those aspects. But then coming to the National Health Law Program really had the opportunity to start digging in on issues related to improving effective communication for individuals with limited English proficiency. And that's where it's really taken off.
Great. So, what are some of the most significant challenges faced by the limited English proficient population in accessing healthcare, in particular, since that's your expertise?
There are many, and we could probably spend the whole podcast just discussing some of those. But, first is just understanding our healthcare system. A lot of times, individuals with limited English proficiency may be immigrating to the United States from another country that doesn't have the same kind of healthcare system or the same public programs. And so, just understanding what programs are available since we don't have national health insurance, how to apply for them, what the eligibility criteria, even just to get in the door if they're eligible. The second is accessing the healthcare. So whether they're going to a clinician's office or a public health department or a hospital if there's an emergency, trying to get effective communication is often a huge barrier. I think many in our healthcare ecosystem unfortunately don't understand the issues that are facing limited English proficient individuals, don't understand the need to really have competent language services, are worried about the costs, and don't always have the plans and the policies and procedures in place to provide effective communication.
Yes, it seems like is a two-way problem, right? On one hand, the limited English proficient person faces many barriers related to how the system works and whether or not they have insurance, but also, as you mentioned, the lack of awareness about how speaking a language different than English would actually have impact in your communication, right? So, in your experience, what are the most effective legislative and administrative measures that have been implemented to protect LEP individuals from discrimination in healthcare settings?
Well, I'm a lawyer, so certainly I care a lot about the laws, both statutes and administrative or agency regulations that we have in place that really can ensure effective communication. Um, we have a number of civil rights laws at the federal level. Many states also have their own state statutes and regulations as well. I think some of the most effective are the broad civil rights laws that we have, one of them being Title VI of the Civil Rights Act that was enacted in 1964, and then more recently, Section 1557 of the Affordable Care Act. I think one of the problems that we face, though, is a lack of knowledge for many individuals with LEP of their rights, and a lack of knowledge of many healthcare providers and entities of their responsibilities under these laws.
Yeah, so tell to our audience, please, what is Section 1557 of the Affordable Care Act and how it specifically addressed the needs of the LEP populations?
So Section 1557 refers to the actual part of the Affordable Care Act, the provision, the number of the provision that was enacted back in 2010. Many people understand the Affordable Care Act as a very broad law that covers a lot of aspects of healthcare. Section 1557 itself focuses specifically on non-discrimination, and it's actually broader than language access. What it does is it says it's preventing discrimination in healthcare on the basis of, these are the legal terms, race, color, national origin, age, disability, and sex. You can see it doesn't mention language access specifically, but the Supreme Court and the Federal Department of Health and Human Services have said that language can be a proxy for national origin. So therefore, if you can't discriminate on the basis of national origin, you can't discriminate on the basis of language. And this has been, again, back from Title VI of 1960, Title VI of the Civil Rights Act of 1964. So what Section 1557 does for those individuals who are protected by the statute is it says if any entity is taking federal funds, it can't discriminate. Any health program or activity administered by the federal government itself can't discriminate. And any entity created under Title I of the Affordable Care Act, which includes the healthcare marketplaces and the qualified health plans that participate in those marketplaces, can't discriminate. So it's a broad non-discrimination provision that not only protects individuals with limited English proficiency from discrimination in healthcare, but prevents all discrimination in healthcare as well.
Yes, I wonder why they don't mention language access, but instead national origin. I wonder if there are other ways to discriminate against a person from a different country. It's just curiosity on my part.
Sure. Well, this goes back to the laws that was written back in 1964. So Title VI of the Civil Rights Act, they use the terms race, color, national origin. I'll be honest, I don't know why they go back, why they use those terms back in 1964. But Section 1557 sort of stands on the shoulders of a lot of these pre-existing civil rights laws. So it builds on Title VI. It also builds on a prior law prohibiting discrimination on the basis of disability and age and sex as well. So the way it was written was sort of capturing those same terms, and we have, where are we, 60 years since Title VI was enacted to understand how the courts and agencies are going to interpret national origin.
Mara, I understand that there were changes and modifications to Section 1557. What specific changes were made to this section with regards to language access?
Sure. So in early May, the Department of Health and Human Services issued new final regulations implementing Section 1557. One thing to be clear, Section 1557, as it was written in the Affordable Care Act, has not changed since it was signed into law in 2010. So that statute remains the same. The regulations are issued by federal agencies to put a little bit more meat on the bones, to explain what it means not to discriminate. So in the regulations that were issued in May, there are a number of language access provisions specifically. So there's definitions of terms related to language access. So that defines national origin. It defines individual with limited English proficiency, language assistance services, relay interpreting, and companions. It also sets out qualifications for those who provide language services. So the regulation says you cannot provide language services unless you are qualified. So you can be a qualified interpreter for an individual with limited English proficiency, a qualified translator, or a qualified bilingual or multilingual staff. Each of those has different requirements. It also recognizes that someone who interprets can't necessarily translate, but that the regulation says you can't just use anyone who you may assume is bilingual, or you can't use a minor or an adult accompanying a patient without actually checking and knowing that they are qualified to do so. There's also prohibitions against using machine translation or automated translation if information is critical to things like the rights or benefits of a limited English proficient individual, or when accuracy is essential, or when the source documents contain complex, non-literal, or technical language. In healthcare, it's really easy to check all three of those boxes. So it's really important that entities are not using automated translation unless it's being checked by a human translator first.
That is awesome. I love the idea that they define these concepts and also that they talk about qualification, because I think that's where the biggest gap is. I can't tell you how many times I get requests for let's say certified translation and or certified interpretation, and they really don't understand what that means. I mean, I hope everybody was asking for certified interpretation and translation, but I also wish they would know what it means. And actually, something to look forward to is I'm going to interview Natalia Mitareva in the future, from CCHI, from the certifying commission on healthcare interpreting, for her to explain all of the key points about being certified. And I also love the fact that they are looking to safety for machine translation and regulating that. We complain all the time in our world that people think that having a translation done by a machine would be a replacement for a translator, for example.
Right, absolutely not. There's a couple other provisions that I should just mention about these final
Mhm.
regulations. There's a requirement for notice. So individuals with limited English proficiency must get notification annually and upon request about the availability of language assistance services. And this notice must be provided in the top 15 languages in the state. And it also has to accompany a whole bunch of other documents. So if a health plan, for example, is sending out an application or a consent form, or you're in a hospital and you're getting information about your cost and your payment, you should also get a notice of availability of language services. And then there's also some specific requirements to develop language access policies and procedures. So all the covered entities must explain how to identify whether someone has limited English proficiency, how to access a qualified interpreter or a translator. They have to have a list of the electronic and written translated materials they are. And if an entity has 15 or more employees, it actually has to designate a Section 1557 coordinator and establish grievance procedures so that individuals who feel that they face discrimination have an ability to file a complaint and to seek relief. There's also training requirements and some other provisions in the regulations.
Awesome. Yeah, no, I love all of the updates. And I particularly like the idea that people will need to be trained on language access. This is something we have developed in Equal Access Language Services, is a language access training. We believe that everybody should know how basically what to do when a person with limited English proficiency crosses the door. And we our vision is that everybody adopts this kind of training. So we at Equal Access Language Services are very happy to hear that training is now not only recommended but mandatory. Is that right, or maybe it's not mandatory?
So the final regulations were released early in May, and most of it becomes effective on July 5th of 2024. Some of these provisions are going to take a little bit longer for entities to put into place. So, for example, there are covered entities, or those who have to comply with these regulations, are given until July 5th of 2025 to develop their policies and procedures. And then the training has to follow the implementation of the policies and procedures. So it's going to be a little bit of time, but within about a year, the training requirements certainly are going to become fully effective.
Wonderful. That's great to know. We will keep up um, with those developments so that we can update our training. Also, is there a place where people can look for these updates? Is there a link that we can offer our listeners so that they can go and download these updates?
Sure. It if you want to see the actual regulations, they're pretty dense and technical, but I can certainly supply a link for that. We at the National Health Law Program have been putting together a lot of analysis of these final regulations. So one publication that we just released looks at the language access requirements both under Title VI of the Civil Rights Act of 1964 and Section 1557, including these final regulations. So we tried to make it a little bit more digestible, and I'm happy to share that link with you as well.
Yes, we will share that link with our podcast. Thank you, Mara. Can you discuss the role of demographic data collection in identifying and addressing healthcare disparities faced by the LEP population?
Demographic data is critical. And there's two reasons. One, as you said, is to identify and address disparities. The second is to ensure effective language access planning. So if we collected data up front, whether it's on an application for a public health program like Medicaid or Medicare, or when someone enrolls in an insurance program, or when someone goes to a clinician's office or a hospital the first time, we would have that data to know who needs interpreters, who needs translated materials, who needs language assistance services. And then on the back end, we'd also have that data to analyze access and quality of care and identify if there are disparities. And then if disparities exist, those entities could hopefully be motivated to identify what needs to change, and they could work to address those disparities. So I think it's very much we need the data up front to do appropriate planning and to know what languages you might see most frequently, which languages you might want to have more staff interpreters or more regular interpreters as opposed to less frequently encountered languages. But we also need to be doing that analysis after the fact to make sure that individuals with limited English proficiency are getting the same access, the same quality of care as everyone else.
Thank you, Mara. What are the main barriers for healthcare facilities to implement the new language access rules?
I think there's a couple of these. One is just understanding that these rules have been released, who is subject to the rules, and how they go about implementing them. So we do have a lot of work to do on outreach and education and implementation and enforcement. Those are sort of my four prongs that I think we need to do. The second, honestly, and we hear this a lot, is the cost. We're talking about civil rights laws that don't come with funding at the federal level. And so we've certainly tried over the year and been successful in limited areas of getting more funding to pay for language services. But a lot of times what we hear from the entities who should be providing interpreters, should be providing effective communication is, where's this money come from? My answer to them is, these are laws, you have to comply with them. You don't ask about whether you have to comply with privacy laws or other laws. And secondly, you can't provide effective care if you don't have effective communication, and you can lead to a lot of errors and problems. People are readmitted to hospitals because they didn't understand their discharge instructions. We actually did a report a number of years ago, and I can provide this link for your listeners as well, looking at the high costs of language barriers in medical malpractice and negligence. And what we found by looking at the closed claims of one malpractice carrier is a number of cases involved either death or permanent disability to individuals with limited English proficiency due to the lack of effective communication. And it also resulted in millions of dollars of payouts in either settlements or legal fees or court cases. So it really does benefit all of us if we're providing effective communication, not just because it's important to do so, but also it's the law and it ensures effective communication.
Yes, when we do the training, we provide our trainees with information related to how if a lack of effective communication can really harm a person. So if they vow to do no harm, really by not providing effective communication through an qualified interpreters, they can end up harming their patients. And another important thing that you mentioned, Mara, about cost is that it's more costly not to plan for language access than to pay for adequate language access services. So yes, absolutely. Please share the link with us. We will make sure to put it to make it available to our listeners. And Mara, all these regulations also cover mental health or not?
Absolutely, they cover mental health. There's no distinction between the type of healthcare access. So there's no, it's as long as sort of the three buckets I talked about with Section 1557 are covered. So either an entity receives federal financial assistance. So if a mental health provider is participating in the Medicaid or the Medicare program or getting research funding or other federal funds, they're absolutely subject to this law. If it's a federally administered program, so public health departments that might provide some mental health services or crisis intervention, those are covered because federal funds are touching those entities. So unless an entity is taking absolutely no federal funds, these requirements are going to apply equally.
Mara, there are many people that are interested in advocacy. If you only had one shot at an elevator speech to convince someone who has the authority and power to implement the updated rules, but is not convinced they should do it, what would you say? This would be a really good nugget for all of those working on advocacy. How would your elevator speech go?
If you or someone you loved, your child, your partner, your parent, was having a healthcare emergency and couldn't communicate with the healthcare providers you were seeking treatment from, how would that feel? And we shouldn't, in this country where we spend way more on healthcare than any other country in the world, we should not be cutting corners by providing ineffective communication assistance for individuals with limited English proficiency. We all have the right to healthcare, and we all have the right to be able to get the healthcare we need when we need it without adding any other stress or barriers on top of what already can be a very, very stressful situation.
How very powerful, Mara. Language access is so important for our immigrants, right? Most of the immigrants to this country are actually limited English proficient. And when they come, they have already endured a lot of discriminatory things, or they are fleeing from violence, they are um, fleeing from poverty. And the last thing that could happen to them once they cross the border is to get sick. So if we think about all the layers of oppression for the immigrants and those with limited English proficiency, and think about all the suffering that goes behind that, um, it would be very helpful if people put themselves in their shoes for once and think how horrible it is to get sick on top of everything and not being understood. So that's very powerful. Thank you so much. Um, what are some of the best practices for healthcare providers to ensure they are compliant with non discrimination protections for LEP patients?
First, I'd say they need to be educated on what the statute and the regulations and the policies provide. So they need to learn about Section 1557 and Title VI and these new regulations. Second, they should plan. They should identify using locally available data, census data, school district data, working with local organizations that serve limited English proficient individuals to identify what languages are most frequently encountered in their areas, who they're serving, who they're likely to serve if good language services were in place, and have the policies and the processes and the contracts in place before someone steps in their door. So that could be identifying who they will use as an interpreter and making sure that person's qualified. And that could be staff people, it could be contract interpreters, it could be telephonic, it could be video interpreters, whatever makes sense. Having those plans in place. Looking at all the points of contact and figuring out how a limited English proficient individual would get through. Telephone systems are one of the most challenging ones, whether you're calling a call center to apply for health insurance or an insurer to get information about what's covered, or even your local doctor's office. How does a limited English proficient person know which number to press if it's only in English? And maybe there's an option for Spanish. What else? So I think it's looking at this and all of the touch points, the public contact positions. Telehealth is another area that we've seen vastly expand during the COVID pandemic. Well, many telehealth platforms couldn't accommodate a third person, such as an interpreter. So now you've completely limited the availability of limited English proficient individuals to benefit from telehealth. So I think it is just looking at every step of an interaction that a limited English proficient person would have with that healthcare provider and identifying ways to ensure effective communication.
Yes, it should be thought as hand sanitizer, right? Everybody knows what to do with hand sanitizer. And I often use these analogies like why don't we think about language access as something that you just need at every step? Like from the moment the person crosses the door of your facility, the person that is at the front desk should know what to do. Or the prompts at the telephone, as you said. I had the experience of calling or asking actually somebody who worked for me, taking care of my American father. She was a nurse and she didn't speak English, and she needed to order the medicines, and the pharmacy didn't have the prompts in Spanish. So I had to tie down my time to help her because even though they say Spanish, there was no prompt for Spanish. So, you have to go through all the steps to be able to be effective. And as a lawyer, can you briefly explain the differences in terms of strength, authority, and scope that a title, an executive order, regulations and the statute have? For example, I know that an executive order is a tool used by a president to direct the executive branch and can be created or eliminated by any president. Executive orders don't have to pass the scrutiny of Congress and therefore is not technically a law. Whereas an act like the Americans with Disabilities Act, for example, is created and approved by Congress to govern various aspects of public and private life, and they don't go away regardless of who is in power. So, can we help people understand what are the differences between all these laws?
Sure, this is my bread and butter as a lawyer. So I'm going to talk about the hierarchy of law. You can think of it as a pyramid, you can think of it as a step stool, whatever seems to make sense. At the very top of this hierarchy is a statute, or we can also call it a law. A statute has to be passed by both houses of Congress, so the House of Representatives and the Senate, and signed by the president. A statute can't be changed without going through that whole process again. So whether it's the Americans with Disabilities Act, Title VI of the Civil Rights Act, as we said, of 1964, Section 1557 of the Affordable Care Act, all of those are statutes. The next step down in our pyramid are regulations. Regulations are developed by, well, from what we're talking about, federal agencies. So the Department of Health and Human Services is what I'm talking about. Regulations provide a little bit more meat on the bones. If you look at the Affordable Care Act and you look at Section 1557, it's 3 paragraphs. It effectively says, don't discriminate. What does that mean in practice? So regulations flesh out those statutes. There's a requirement that when an agency is adopting regulations, it has to first propose regulations, take public comment, so anyone in the country can participate in this rulemaking process, consider all those comments, and then finalize the regulations. So these Section 1557 regulations that we've been talking about that were issued early in May actually are the third set of regulations we've had on Section 1557. So Section 1557 was enacted and signed into law in 2010. President Obama's administration put out its first set of regulations in 2016, I believe. President Trump changed those regulations, went through a whole new process. You can't just unilaterally decide they don't like the regulations. They have to propose new regulations, take public comment, consider the comments, finalize the regulations. So President Trump issued regulations in 2019. And then when President Biden came into the presidency, there's been a third set of regulations. So regulations can't be changed without a new public comment process. And usually there's a requirement something else has changed. There's some reason you're making changes to these regulations. The third step down, we've got our statute on top. Then the next step down is regulations. The third step is what we call guidance. These are also developed by federal agencies and sometimes the White House. Usually there isn't any public comment process, and they can be changed unilaterally by the agency. So this does include executive orders, which are issued by the White House and the president. It also can include sometimes guidance or frequently asked questions or things like that. So if we look at, again, what we're talking about, the statute is Title VI. The statute is the Affordable Care Act. The regulations, we've had these three sets of regulations. There are also our Title VI regulations that have been around since soon after that law was enacted. And then guidance, many of you might be familiar with the HHS LEP guidance from early 2000. There's also a number of documents on a government website called lep.gov. A lot of those are guidance as well, providing a little bit more information, but don't sort of have that same power to enforce and to require compliance.
Is there any risk that Executive Order 13166 goes away with a future president?
Certainly. And if it goes away, however, we still have the underlying statutes on which it was based. So what Executive Order 13166, which was signed by President Clinton, said is it reinforced the requirements from Title VI from 1964. And it applied Title VI to the federal agencies themselves. So it's a little bit of a weird quirk. You'd say, well, don't federal agencies get federal funding? Technically, even though their money is coming from the Treasury, it's not considered federal funding. So a hospital, a clinic, whatever was subject to Title VI, but the federal agencies themselves were not. However, with regard to Section 1557, the statute, that piece of the Affordable Care Act, also does apply to federal agencies themselves. So even if we lose Executive Order 13166, which I hope we don't, we would still have these statutes in place that require the same things. Again, unless and until you get a new Congress and a new president who pass a new law and sign a new law. But that's a lot harder to do.
Mm-hmm. In your opinion, how can advocacy groups and policymakers collaborate to enhance the enforcement of existing language access laws and regulations?
A lot of what I think needs to happen is education. We need to educate individuals with limited English proficiency about their rights. We need to educate healthcare providers and insurers and entities who are subject to 1557 about their responsibilities. We need to do this comprehensively, and we need to do it over and over and over again. We also need to make funding available. There needs to be funding to do this outreach and education and training. There needs to be funding to train qualified interpreters and qualified translators and qualified bilingual staff. We also would be great to have funding to actually pay for language services. We've been trying to do that for years. For example, to get Medicare to reimburse for language services. And unfortunately, we haven't been able to move that through Congress and get it signed into law yet. But I think a lot of it is again, this education right now to ensure effective implementation. And then if discrimination is still happening, enforcement.
Is that, do you do a lot of community engagement in your current role?
Certainly, I do a lot of presentations and talk to folks like you and try to get the word out. So we've certainly done a number of webinars, both on Section 1557 as a whole, looking at all the aspects of discrimination. And I've been doing a series of webinars just on these language access provisions. And my organization does a tremendous amount of training, and we present at conferences, and we've gone to interpreter conferences sometimes in the past as well, or the American Translators Association. So we really are trying to get the word out and just work with everybody that we can to help really understand that these are very strong, very important regulations, and we all need to know what they say and make sure that these practices are happening on the ground for every individual with limited English proficiency who needs them.
Yes, I can't wait to the time when limited English proficient persons understand their rights and demand those rights from entities. I think frequently I see that, for example, there is a conference or something that would benefit the limited English proficient population. The client is offering interpretation, but nobody takes advantage of that because there is this preconceived notion that it's going to be in English and there is no language access to them. So I can't wait to the day we are more aware of our rights, the limited English proficient people. And as I said, sometimes I count myself among the limited English proficient population. But yeah, that would be ideal. I think knowing your rights is an important step to really changing society. Given your extensive experience, what are the key areas where you believe policy upgrades are necessary to prevent discrimination against LEP populations? And how can insights from other advocacy groups can guide these upgrades?
Well, I work in the federal sphere, so I do have sort of a focused hat of what I think needs to be done at the federal level. So I'll probably speak more to that. I think one, we need more funding. So we need funding for this outreach and education campaign to be able to do it in multiple languages. We need ongoing funding for all communication campaigns that are done by federal agencies. So, for example, federal government recently released a new website to help individuals file complaints where violations of the Emergency Medical and Active Labor Treatment Act are happening. So if individuals are going to hospitals and are supposed to get emergency treatment and aren't getting that website was released only in English. Even these regulations are only in English. There's fact sheets and information in other languages. But so we really need to be thinking about language access up front, maybe even before a campaign begins, whether it's a new education campaign, an outreach campaign, a new grant program that might be beneficial, things like that. I think the Office for Civil Rights needs a lot more funding. They need funding to do this outreach and education. They need funding for enforcement. So the Office for Civil Rights at HHS does receive complaints when people believe violations of Section 1557 or Title VI or other civil rights laws occur. OCR can investigate the complaints, and they can work with entities to come into compliance with these laws. So we'd like to see, more complaints. We'd like to see OCR staff increase so they can investigate more of these complaints and get the information out about what needs to happen. And then, as I said before, I'd love to see Medicare start paying for language services. But I also think a lot can be done at the state and the local level. Advocates can really work to get state funding to help pay for language services, whether that's in healthcare or other arenas, to get funding to support the training of interpreters and translators, to, again, do outreach and education campaigns, as you said, to make regular everyday programs and activities accessible. School board meetings, county council meetings, state legislative hearings, all of those. Like, people should be encouraged to be active participants, and it's very hard to do that if you have a language barrier.
Yes, and one of the things that we need to pay attention to, and I believe you mentioned this as part of the updates of Section 1557, is the use of children to overcome that language barrier, right? Can you speak to that, to how the new regulations address that problem and why it is a problem?
Sure. So a lot of times, healthcare providers or entities may not have planned in advance or may not have developed their own policies about who can be qualified to interpret. And if a patient comes in and they don't have a qualified interpreter available, they grab anyone. They grab someone from their own staff, they grab someone accompanying the patient, and a lot of times, often those minor children. The final regulations here prohibit the use of anyone accompanying the patient, whether it's an adult or a minor, except as a temporary measure in emergencies. And again, this gets back to the regulation saying only qualified individuals should be interpreting. And most of the time, a minor in particular, but also even another adult accompanying a patient, doesn't have the requisite knowledge and skills and abilities as an interpreter. They might not be sufficiently bilingual in both English and the non-English language. Particularly, they're usually not going to know the specialized terminology. We've unfortunately seen children being asked to interpret in trauma situations in an emergency room, or to explain to their parent a diagnosis of cancer. It's traumatic enough to have to deal with the diagnosis, but to then have to explain to your parent with terminology you don't understand and have to assist in treatment, that puts so much stress on the child in a way that they should never have to be in that moment. It also sometimes can flip the family roles, that the child actually has to become like the adult if they're asked to interpret for their parent because the parent can't serve in that role. So the regulations recognize this and really say that you can't expect a minor to interpret, really, if it's short term while you're getting a qualified interpreter in place. And if you're using an adult accompanying a patient, it has to be appropriate under the circumstances. You have to document that everyone agrees to do that. And if there's reason to know that that accompanying adult isn't providing a sufficient interpretation, then that adult should not be used as an interpreter.
I can think of many cases where they can find a qualified interpreter, for example, in Spanish. But for cases where there is a rare language or an indigenous language, I am sure that can happen. Are there any provisions that speak specifically to languages of lower diffusion or indigenous languages?
There's a couple things that I think the regulations recognize inherently in them. The first is, well, and this isn't really mentioned in the regulation, but it's how the language industry sort of operates. A lot of entities may have a contract with a telephonic or a video interpreting company that can usually provide interpreters in sometimes 150, 200 languages within a very short period of time. So that's usually sort of the first way to get language assistance. The regulations do recognize that sometimes you may need to use relay interpreters, so that you may have someone who speaks, let's say, an indigenous language and Spanish, and then someone's going to do a secondary interpretation from Spanish to English. And that's recognizing the definition of a qualified interpreter for an individual with limited English proficiency, and that's recognized in these regulations as something that may happen. So again, we need to be really careful that we're not making assumptions that, oh, they're from Mexico, therefore they're going to speak Spanish. We really have to identify what language that person is speaking and make sure we have the right language services in place.
Great. I'm glad that this is mentioned in the regulations. Is there anything else you would like for me to ask that I didn't ask, Mara?
I want to emphasize enforcement a little bit. I touched on it briefly, but I do think it's really important that folks again understand if they face discrimination, that they do have an ability to file a complaint. Sometimes it may start with the entity itself. They can file a grievance or a complaint with the hospital or the clinic or with their health insurer. But they also can file a complaint with the Office for Civil Rights. And it actually doesn't have to be the individual who faces discrimination to file that complaint. An advocate, a healthcare provider, an interpreter, anyone can file those complaints on someone's behalf. And I think that's also really important because one of the issues we sort of didn't quite touch on directly is many individuals with limited English proficiency may have concerns about bringing a complaint because of their own immigration status, or they're concerned, often erroneously, that it may impact their ability to sponsor someone in the future. But I think again, when we look at when we look at language barriers and a lack of knowledge of the healthcare system, many individuals with limited English proficiency might not understand the complaint process or want to get involved, but others can do that on their behalf as well.
Yes, there is a lot of fear in the limited English proficient population that about placing any type of complaint. They often, or at least this is what I have experienced as an interpreter. For example, when people suffer from some kind of crime, they are even afraid of going to the police because they think that that's going to have bad repercussions on their immigration cases. On the other hand, I'm glad you mentioned interpreters as people that can place the complaint on behalf of somebody, because there is also a lot of fear from interpreters to raise any kind of issue. I think part of this, and I invite any of my colleagues to comment if they hear this and whether they are in disagreement or agreement. But since we are not supposed to advocate during the session, unless the well-being of the person is at risk. Then they expand that part of our code of ethics to never advocate in any case. And I think that's incorrect. There are circumstances where the person is treated unequally, and we should say something outside of the session to correct that situation. I believe that that's part of our role, and I heavily promote that. So I'm glad you say that even interpreters can actually submit complaints and do it in a way that is going to be helpful and is not going to violate in any way the actual interaction. So thanks for bringing that up. Anything else, Mara, that you think we should mention?
Well, just picking up a little bit on what you just said, I think that interpreters and healthcare providers can also serve a role as an educator. For example, the link that I'm going to give you about explaining Title VI in Section 1557. If someone feels that a healthcare provider is not complying with this, sometimes they might not know about it, which I I wish wasn't the case, but we still do hear this from healthcare providers. So share information with them to help them understand and educate themselves of what their responsibilities are. I think that's one piece. And again, find ways within communities to, again, help educate individuals with limited English proficiency about their rights and about how to request language services, and how to ensure that they're getting what the law requires.
I remember a few years ago, I suggested that we introduce ourselves, as interpreters, and that we said to the patients that they had a right to language access, not a right necessarily to an in-person interpreter, but language access, which is a lot broader. And I faced a lot of pushback about that when I trained interpreters, because they felt that could put them in trouble. Now I think that perception has changed, and people are more willing to say, you have a right to language access. And I think it's interesting that I think our consciousness has changed with regards to language access. Do you perceive there has been a change from, I don't know, 20 years ago when you started to now with regards to this topic?
Well, I think there's certainly been more focus on the needs of individuals with limited English proficiency. And so we do see more recognition of um, the federal laws, but also the limits on the funding. And so I think it ebbs and flows. And I'm hoping again with these regulations, we're on that upward trajectory of really helping to improve language access and ensure effective communication. So I remain optimistic. We still have a lot of work that we can do, but I think we have a lot of good tools in our toolbox right now that we can be using to improve language access and ensure effective communication.
Yes, and definitely I really want to say to my fellow interpreters that we're part of the solution, where language access advocates just by the role that we perform, and that I join with you in the hope for a better future with this topic. Thank you, Mara. I'm delighted that you were part of our podcast, the 10th episode. And I hope also that language access and the conception about language access goes in an upward direction. And knowing that we have more tools in our toolbox is going to help us ensure that limited English proficient persons have better healthcare. So I look forward to a future interview with you. I hope this continues to develop and that more hospitals and healthcare facilities adopt the Section 1557 of the Affordable Care Act.
Thank you so much for inviting me.
Thank you, everybody, for joining us. And that wraps up another enlightening episode of Language Access Matters. We hope you have enjoyed our discussion on the profound impact language access has across various sectors of society. Let's remember that language access is not just an isolated topic. It intertwines with various fields, impacting lives and businesses in profound ways. As we continue this journey together into becoming a more inclusive society where we ensure equal access to services to those who don't speak the dominant language, we want to assure you that our company, Equal Access Language Services, through its podcast Language Access Matters, will be with you every step of the way. We are committed to bringing you thought-provoking conversations, expert opinions, and stories from the field and beyond. To dive deep into the subject matter and engage with leading experts in the field, we will release a new episode of Language Access Matters once a month. By featuring expert practitioners and individuals with diverse experiences, we aim to broaden the scope of our discussions and present a comprehensive view of the importance of language access. We encourage you to stay connected with us through our website, www.equalaccesslanguageservices.com, and our social media platforms. You can join the conversation, ask questions, and share your own stories and experiences. If you want to be part of our podcast, email us to podcast@equalaccesslanguageservices.com. Remember, language access matters to each and every one of us. By understanding its significance and actively working towards its advancement, we can create a more inclusive and equitable society. Thank you for being a part of the Language Access Matters community. We appreciate your support and look forward to sharing more knowledge, inspiration, and empowerment with you in our future episodes.